This ASCRS bootcamp presentation will focus on the diagnosis and management of acute lower GI bleeding.
The objectives of this bootcamp video are to explore pertinent questions when thinking about a patient with rectal bleeding, determine the tools needed for evaluating these patients, understanding the important tests order, reviewing the differential diagnoses, and highlighting the key exam findings. It is August 2nd, and your first night on call as a colorectal fellow. You get a call from the emergency room. Dr. Smith has a patient they want you to see right away with bright red blood per rectum. Important questions to ask include their vital signs. Tachycardia and hypotension often indicate significant hypovolemia. Does the patient have orthostatic vital signs, which also may indicate significant hypovolemia? Take caution in patients who are on beta blockers, as this may mask the response to hypovolemia. Ask about the character of the bleeding. Is it bright red blood per rectum after bowel movements? This is usually an anorectal source. If it's massive hematochezia, this typically is more consistent with a colonic or rectal source, and melena is almost always more consistent with an upper GI source. Has the patient had any prior similar episodes or prior hospitalizations for similar episodes? Have they had any prior diagnostic studies such as colonoscopies or CT angiographies? Have they had any other prior therapeutic interventions performed such as therapeutic colonoscopies or mesenteric angiography with embolization? Do they have any other symptoms such as chest pain or shortness of breath? Do they have syncope? Are they dizzy? Is there associated abdominal pain or cramping, or do they have tenesmus? Are there any comorbid conditions? Pay particular attention to conditions such as coronary artery disease, peripheral vascular disease, or congestive heart failure, as these patients are more likely to be on blood thinning agents, which may exacerbate the bleeding. Are they coagulopathic? Do they have any indication of renal disease, in which case you may consider alternative diagnostic imaging studies? Again, ask about blood thinning agents and beta blockers. Ask about the patient's surgical history. Have they had prior colon surgery? Have they had prior hemorrhoid surgery? Have they had prior radiation to the pelvis for prostate or cervical cancer? When was their last colonoscopy? When was their last CGD? And what were the findings at that time? It's important to gain adequate access on these patients in order to large bore peripheral IVs for rapid resuscitation. If the patient's hemodynamically unstable, rapid infusion of 2 liters of crystalloid should be started. Basic laboratory work includes a CBC, basic chemistry panel, coagulation studies, and type and cross-match the patient. In the setting of massive transfusion protocol, keep in mind that you may also need to give platelets or fresh frozen plasma. If the patient has a history of coronary artery disease or is having chest pain, an EKG should be obtained. And the NG tube lavage is essential. A bilious return on the lavage indicates a negative lavage, meaning that it's most likely a source of bleeding distal to the ligament detritus. If you get blood or coffee grounds back, obviously that indicates an upper GI source. Clear return indicates an indeterminate source of bleeding. You could still have a upper GI bleed distal to the pylorus with a clear return on the NG lavage. Things to think about as you're heading to the emergency room: you need to have adequate lighting. The ER often does not have good headlights, so it's important to bring a headlight with you. If you don't, lighting is essential to have a good view of the anus. It can either be a battery-powered headset or older models to plug into the wall. Oftentimes, you need to bring these from your outpatient clinic. An anoscope is important for visualization of the anus. Oftentimes, you can find pathology that is not easily seen on colonoscopy. You need to have some sort of light source to go along with the headlight, or an anoscope with an indwelling light source. You need to have some sort of suctioning available. You can visualize the anal canal, and if you do find something bleeding, it will facilitate suturing or cautery or permit better packing or banding of a bleeding hemorrhoid. Here you see traditional non-lighted anoscope on the left, where you would need to have an external source. The plastic disposable anoscope on the right has an indwelling light source that is self-powered. You should bring a proctoscope with you as well, either the disposable type or the reusable type. Most of these have light sources built into them, the disposable ones, but if you bring a non-disposable, you may need to bring a light source with it. Again, you need to have proctoscopic suction for visualization, and via the scope you can perform some therapeutic interventions with either cautery or Schneider. This is the non-disposable proctoscope. It comes in several parts. You have the scope itself along with the obturator which goes within it, and then the power cord for the light source, and then the air bladder to insufflate the rectum via the proctoscope with. This is a totally self-contained disposable proctoscope which has an indwelling light source. It's designed for single use. Use it once and throw it out. This is the suction head for a proctoscope. Note the much longer, slenderer profile of the suction head as opposed to the traditional Yankauer type, so that it fits within the long, narrow confines of the proctoscope. The differential diagnosis is wide-ranging, and beyond the scope of this talk, things to consider include hemorrhoids, anal fissures, bleeding diverticular disease, arteriovenous malformations, anal neoplasms such as anal cancer, rectal polyps, ischemic colitis, inflammatory bowel disease, or radiation proctitis. Additional less common diagnoses include post-procedural bleeding, such as that from hemorrhoidal banding or endoscopic polypectomy, rectal varices in patients with portal hypertension, infectious colitis, HIV-related proctocolitis, anorectal trauma, or an otherwise inconspicuous upper GI source. Key findings on the perineal inspection should include prolapse of either hemorrhoidal tissue or full-thickness rectal prolapse. You should take note of any anal skin tears or fissuring, including the location of the fissures. You should look for any external skin lesions or neoplastic lesions, as well as external sources of drainage, such as that seen with an abscess or a fistula. Digital rectal exam should assess for any palpable masses, fluctuance, or fullness. You can also check for gross blood on the digital rectal exam. Anoscopy should be performed to circumferentially evaluate for internal hemorrhoids. Prior to performing anoscopy, one should confirm that there is no presence of an anal fissure, which may limit the patient's tolerance to the exam. If there is no anal source of bleeding noted, proctosigmoidoscopy can be performed to assess the more proximal rectal mucosa. You should evaluate for proctitis, masses, or other lesions, and look for a more proximal source of bleeding. Tests that can be done in an acute setting include CT angiography, which is the most commonly performed test now for acute lower GI bleeding after excluding an anorectal source. This is often limited by the patient's renal function, in which case a radionucleotide scintigraphy can be performed. This is much more sensitive for picking up slower rates of bleeding, but much less sensitive in terms of identifying a location. Mesenteric angiography can be performed if acute bleeding is noted on a CT angiography to both confirm the site of bleeding and perform therapeutic procedures such as embolization. Lastly, colonoscopy can be performed in an acute setting after a rapid purge of the GI tract to allow for adequate visualization. Diagnostic tests that can be performed in a more delayed fashion for slower bleeds include video capsule endoscopy, a Meckel's, nucleotide scan, and double balloon enteroscopy. Hopefully this boot camp video has been helpful in terms of helping you understand the basics of evaluating and managing the patient in the emergency room with acute lower GI bleeding. Thank you for your time.